Okay, so good evening or good afternoon, everyone. So let's quickly run through cardiopulmonary resuscitation in children. All right, we'll follow this outline. All right, so learning outcomes. What do we hope to achieve? We want to appreciate cardiopulmonary resuscitation in children. Look at the causes of cardiac arrest, common causes of cardiac arrest in children. We look at recognition of cardiac arrest in children, overview of the 2010 guidelines. Then we look at the 2015, and we'll look at compare 2015 and 2020, and we'll look at some other scenarios where CPR in children have been performed. All right, so cardiopulmonary resuscitation is the use of chest compression and assisted ventilation in order to maintain circulatory flow and oxygenation following cardiac arrest. So it's the use of chest compression and assisted ventilation in order to maintain circulatory flow and oxygenation following cardiac arrest. So you need to underline that. So the sources of CPR or cardiopulmonary resuscitation actually largely rest on the adequacy and the efficiency of your chest compression and your assisted ventilation or rescue breath. As we know, CPR is one of the most commonly performed emergency procedures, both in the emergency room and intensive care unit, even also in the theater. And for many of us, or some of us, would have witnessed an incident of cardiac arrest on the table. So it's a very common procedure that the anesthetist and critical care physician is very aware of. So leading causes of death in pediatric age group differs. In infants less than a year below, congenital malformation, complications of prematurity, or we have what they call the sudden infant death syndrome. In children, to adolescents, injury, traumatic injury, and all forms of injury are the commonest causes of death. Now, just to remind ourselves, the reversible causes of cardiac arrest across all ages, the 6H and the 5 T's. All right, the hypovolemia, hypoxemia, hydroxyurea, which is acidosis, hypoglycemia, hypo and hyperkalemia, hypothermia, tension pneumothorax, cardiac tamponade, and pulsings, thrombosis, most of the time, pulmonary, and we have coronary thrombosis, which can lead to stroke, and cardiac arrest depends on how massive it is. So these are reversible causes of cardiac arrest, and when a patient goes into cardiac arrest, we want to actually try as much as possible to identify those reversible causes and treat them as we initiate CPR. All right, so the pathway is actually a form of respiratory failure and cardiac failure, hypotensive shock. Both of these lead to cardiopulmonary failure, hypoxic, and cardiac arrest. All right, the other one, the sudden ventricular arrhythmia, leads to sudden cardiac arrest that a lot of times may be amenable to early defibrillation. And in the course of this lecture, we're also going to emphasize the importance of early defibrillation and the place of AED in out of hospital CPR, cardiopulmonary resuscitation. So in the pediatric age group, cardiac arrest can be due to respiratory causes, and we know that hypoxia is one common cause of reversible cardiac arrest, especially in children. So this can result from airway obstruction, from aspiration of foreign body leading to choking, respiratory infections, respiratory failure due to underlying medical conditions. Circulatory causes can include arrhythmias, congenital defects, cardiomyopathies, and all that. These are things you can go through as you have the slides with you. So sudden infant death syndrome is a sudden unexplained death of an infant under the age of 1 year. It's unexplained, it's sudden, and the infant just died. So it's a common cause of pediatric cardiac arrest. So when you just take a look at the differences between cardiac arrest, CPR in children and in adults. All right, we're going to look at it in different perspectives in terms of compression. All right, you want to look at the depth. In pediatric CPR, compression are generally shallower. All right, you're about 1.5 to 2 inches. And compared to adults, which at least you get about 5 centimeters to 2 inches. The placement of the hands for chest compression, 2 fingers are used for chest compressions. In infants and in older children, you can actually use the heel of one hand as against that of adults, all right, where you can use 2 hands. The rate of compression are similar, about 100 to 120 compressions per minute. All right, for infants and young children, mouth-to-mouth or nose-to-mouth rescue breaths are recommended. And for older children, it's the mouth-to-mouth rescue breaths are preferred. The volume of ventilation should be enough to cause visible chest rise, but be careful also not to cause over-distension and over-inflation. There are different techniques and different types of AEDs. There are special pediatric pads and settings, and the different settings in which AED may be used for children under 8 years old or weighing less than 55 pounds. And what is that in kilogram body weight? For larger children, we can use adult AED pads, and settings are practically the same as that of adults. I want you to take note of this. So the pediatric chain of survival, according to the American Heart Association, this is 2015 guidelines. We'll look at some of these things as we go on. So types of CPR, generally we have the conventional CPR with chest compression followed by rescue breaths. In some occasions, compressions alone CPR, it's recommended, especially when the rescuer is not comfortable to do mouth-to-mouth. But know that the American Heart Association actually recommended compression alone CPR for infants. So it's important that if the refusal or unwillingness of the rescuer to do mouth-to-mouth or give rescue breath should not stop effective compression, because it's been found that it's can be very effective for primary cardiac events. So initiation of CPR in 2015 was ABC. In 2020 is CAB. You start with chest compression. Once you satisfy yourself that this patient is in cardiac arrest, you want to do chest compression with airway and breathing. Note that the time to initiation of chest compression should be reduced. You should, because the truth is you want to minimize the low blood flow time. All right. So the earlier you start chest compression with the aim of initiating spontaneous return of spontaneous circulation, the better. So you want to immediately start CPR and reduce the low blood flow time. Chest compression, I mentioned before, is about 100 to 120 chest compressions per minute, and it should at least cover about 1/3 of the anterior posterior diameter of the chest. In infants, 4 centimeter, children, 5 centimeters. Adolescent and adults should actually be more than 6 centimeters, between 5 to 6 centimeters. All right, defibrillators. Sometimes we have different types of arrhythmias that lead to cardiac arrest. And we know that we have tried to differentiate between shockable and non-shockable rhythms. And the beauty of AED is that it has voice prompts and analyzes the rhythms and gives you prompts whether this rhythm is shockable or not. But AED is available for children less than 8 years old or less than 25 kg. All right. For the other ones, the other one, you want to give first energy dose of 2 joules per kg. Second dose, you double it. And subsequent dose, you maintain at 4 joules per kg, but do not exceed 10 joules per kg for your current, still current. Like I mentioned before, the differences between CPR in adults and children. For children more than 1 year old and greater than 10 kg, you want to use the adult size and you want to use the adult placement. Put it, the right is just below the clavicle, while the left is below the nipple, lateral to the nipple, below the axilla. For infants less than 1 year, less than 10 kg, you just put the part below the, on the sternum below the mammary line, and you put the other one between the two scapula, all right, at the back. Now, so the importance of early defibrillation, all right, especially those shockable rhythms. Defibrillation helps to restore the normal rhythm of the heart and can actually save the child's life. And also, early defibrillation is a vital link in the chain of pediatric chain of survival that I showed you before. And this includes early recognition of cardiac arrest, early CPR with effective chest compression, and early advanced life support. Note that the sooner an AD is applied and a shock is delivered, if needed, the higher the chances of survival and positive neurological outcomes. Now, there's been a drive, especially in public settings, for public access defibrillation programs, which should be placed in schools, sports facilities, and other public places. I've actually arranged with the chairman of the Central Tennis Court in Olympia in Vidocare, and I'm going to be giving them lessons or some tutorials or hands-on on CPR, because we have some elderly citizens, all right, who come to play tennis. And I've noticed that it's important for everybody on the tennis court to be able to perform CPR. So public asset defibrillation, I will move that we have an AED in that sports, in that central tennis club, so that if any of the members while playing tennis suddenly slumps and have cardiac arrest, you can have immediate access to care. And this is a move that we should also encourage in different places. In the malls, I am aware, or rather I heard, I'm not sure, I didn't see it, that there's an AED in Groove Mall. I don't know if we have in other malls, and not to talk about in Katutura and other places. So we should implement public access defibrillation programs. All right, so this is like an algorithm, and we'll come to that a lot. If we have time, we'll come to that. This is just explaining the update between 2010, 2015. We've moved past that now. We have 2020, all right, which emphasizes CAB rather than the ABC. Okay, we'll see if we can come back to all these ones. This is just for you to see this, okay? All right, so there are some drugs that are used in CPR, especially after the immediate BLS. You want to move to ALS, and adrenaline, like cocaine and amiodarone, very important drugs that should be in our armamentarium. So for epinephrine or adrenaline, we can use either the intravenous or the intraosseous route, and it's at a dose of 0.1 ml per kilogram of 1 in 10,000. We can also use the endotracheal tube route, which will give you about 0.1 milligram per kg of 1 in 1,000 adrenaline. Lidocaine, in cases of arrhythmias causing cardiac arrest, you can actually use them through the intravenous or intraosseous route, and you give a loading dose of 1 milligram per kg, and you can maintain with 20 to 50 microgram per kg per minute. Amiodarone is very useful, especially in cases of SBTs and atrial fibrillations and all that. Atrial fibrillation actually responds very well to amiodarone, and you can use both the intravenous and intraosseous route at the dose of 5 milligrams per kg. All right, in cases of refractory ventricular fibrillation or pulseless ventricular tachycardia, you can repeat the dose of your amiodarone up to twice of your initial dose. Now, there are some scenarios CPR may be needed in an infant, all right? And the first one is choking, okay? Like my name of the signs of choking in a child is choke. So when a child is choking, all right, you want to look at the cough. If the child has weak and ineffective cough, or there's no cough at all, then you have high-pitched sound, all right, like the oxygen failure sound that you hear in theater, high-pitched sound, and the sound becomes soft when the child is trying to inhale. You have signs of obstruction, stridor and all that may be present in the patient leaning forward, trying to gain mechanical advantage. And the patient is unable to cry. You see that the patient is in distress, but is unable to cry. All right. And at the end of the day, the patient becomes exhausted and not responsive. At this point, where the patient becomes unresponsive and exhausted, that's when you need to initiate CPR. So how do you manage this? All right, you give 5 back thrusts, and I'm going to come to that because there are some pictures we can see. So you continue 5 back thrusts, 5 jet thrusts, until the object is expelled. All right, whatever it is. We had a patient we just recently discharged from the surgical and trauma ICU here in Windhoek. The child had swallowed a coin, so to say, and the child was taken to the clinic for a long time, for almost 3 months, being treated for upper respiratory tract infection, until the child was referred to Windhoek, where they did the reading bronchoscopy and the esophagoscopy, and they found a coin, and because this patient became pathetic, lost weight, because he couldn't eat because of the dysphagia and all that he had. So you continue chest back thrust and chest thrust until the object is expelled. Once you are able to appreciate the signs of choking, and if the object is there's no visible object expelled, you open the airway, and if you see the object of that vision, you remove it. And if this is not successful, just commence CPR. All right. And sometimes when we have foreign body aspiration or ingestion, sometimes if it's in the oropharynx, the patient is in theater during laryngoscopy, you can actually most times see the objects and you can remove them with your forceps under the air vision. All right, so this is the back thrust I'm talking about. Place the infant stomach down across your forearm, all right, and give 5 back thrusts on the patients with the heel of your hand. All right, this should help to expel any objects that may be causing the choking in the child. So you need to it requires good techniques for it to be effective to expel the object. All right, you place the 5 chest thrusts. You place your 2 fingers in the middle of the infant's sternum and give 5 quick downward thrusts. All right, that should also help to expel. But you continue, but the catch is you should know when to commence CPR when or if all of this fail. For the child above 1 year, maybe between around to adolescence, you can actually do your Heimlich maneuver, your abdominal thrust. And the technique is important to learn. All right, so you place one fist just above the umbilicus with the thumb side facing the abdomen. All right, do not thrust hard enough to lift the child off his feet. All right, so technique is very important, and I think practice would help. So this is your chest rescue breath according to the American Heart Association. You want to close the nostrils and open the mouth with either your jaw thrust, and you give your mouth to mouth. You look at the chest, you give enough for chest rise, but not too much to cause over distension, over inflation. All right, for initiating advanced life support with your airway, all right, we are all anesthetists, remember. Okay, and chest compression after you tried and you decided to do chest compression. So there are two ways you could do it. All right, you can do 2-finger chest compression technique in infants if you're a single rescuer. When you put it at the center of the sternum and you compress about 1/3 the anterior posterior diameter of the chest. And then this chest compression, you can, okay, this is another one. You can just put 2 thumbs on the chest if it's younger. And for instance, infants and neonates, this is an effective way of doing chest compression. All right, in the older child, it's like the adults. You place the heel of one hand on top of it, on top of the chest, all right, in between just slightly below the chest, around the nipple, the imaginary line between the nipples, just immediately below it, put the heel of one hand on top of it, all right, and you clasp your hands with the other hands, and with your elbow straight, you want to compress to about 4 to 5 centimeters in the older child, at the rate of 100 to 120 compressions per minute. The effectiveness of chest compression determines a lot of times the outcome of CPR in children, even in adults. Okay, so common pediatric CPR scenario, I've mentioned that of choking. We have other cases, especially drowning. There was a child, there was a story of a woman who took the children, took a child or a son to the swimming pool, and the child was drowning. And motherly instinct, she jumped into the pool to help the child, and both of them drowned and died. So these are common pediatric CPR scenarios. A drowning child. So how do you recognize a drowning child and requiring CPR? So you want to look for unresponsiveness in the child. The child near or inside water is unresponsive, is unable to keep his or her head above water, or you can see the child gasping for breath. So you quickly remove the child from the water, and you check for responsiveness and breathing. If not responsive and not breathing, you want to start CPR immediately. And the aim is to restore breathing and circulation as soon as possible after a drowning incident. All right, sometimes the child may be eating something and develop anaphylaxis, all right, requiring CPR. So symptoms will include difficulty with breathing, swelling of the face and throat, with some, urticarias. You could have weak or rapid pulse. Now, if you have the EpiPen, which is the epinephrine autoinjector, you want to administer it immediately. Call the emergency service and follow the instructions. But importantly, if you are a trained rescuer, it's important that it's good to call for help, but you must be prepared as a trained rescuer to start CPR for this patient, who has developed anaphylactic reactions. All right, I mentioned this before. Okay, let's look at high quality CPR. Like I mentioned, chest compression is very important. So you want to push as fast as possible. There's this reading I saw recently. It gives you, in fact, I think it's an app that we can download on our phones. So when you're doing a chest compression, it gives you the rate at which you should go, toe, 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 so you follow the rate of the arm. So you push fast as possible to maintain chest compression at the rate of 120. So if I ask you, what are the components of high quality CPR? This is what I want to see. All right. A lot of times when questions are asked in the exam, the way we answer it is important. So if I ask you, give me 6 components of a high quality CPR, this is what I'm looking for in terms of the rate of chest compression. We should be between 120 compressions per minute. You want to push hard to more than 1/3 or 2/3 of the AP diameter of the chest. And if you want to put maybe 4 to 5 centimeters or 1.5 to 2 inches. You must always allow a complete chest recall because this is important for coronary circulation. You do not want to just compress and impede coronary blood flow. You want to minimize interruptions in chest compression because this is a mechanical push. The heart is not pumping blood, it is the compression of the heart against the anterior and the posterior chest wall that is pushing blood into the circulation. So you want to minimize interruptions. You want to rotate the compressor every 2 minutes. You know, we're doing a training sometime and a hefty young man I thought was strong, tried it and it didn't last up to 10 compressions. All right, then although later I said he had problem with his shoulder. So for effective high quality CPR, you want to rotate the compressor every 2 minutes or and sooner. But the truth is, the person who is compressing should be able to say, I'm tired, and somebody take over. Can somebody take over the person rest? Go ahead. So if there are no advanced airway, you want to do 30, but in children, you want to do 15 to 2 compression ventilation ratio. All right, but if, for instance, in check that the patient is intubated or has a tracheostomy, you want to do compression rate of 100 to 120 per minute and 1 breath every 6 seconds. All right, so you give about 10 breaths in 1 minute. So the way to understand it is 100 chest compression per minute, 10 breaths per minute when you have the airway institute. 100 per minute of compressions and 10 breaths per minute of your breath. All right, so the differences between American Heart Association CPR guidelines 2015 and 2020. All right, I'm sure you can just go through this. All right, in terms of the depth, in terms of the rate, and in terms of the sequence. All right, so this is all right. So now, what are the takeaway points for the 2020 Paediatric CPR guideline? Note that high quality CPR, there's no way I want to ask this question. All right, what are the components of high quality CPR? Because this is the foundation of restoration or return of spontaneous circulation, your ROS. High quality CPR is the foundation for return of spontaneous circulation. All right, providing adequate chest compression, rate and depth, minimizing interruptions in CPR, allowing full chest recall between compressions, and avoiding excessive ventilation. So this is one of the take-home points from the 2020 guideline. A respiratory rate of 20 to 30 breaths per minute is new for infants and children who are receiving CPR with an advanced airway in place, all right, or who are receiving rescue breathing, but they have a pause. So, but don't forget I mentioned chest compression, 100 chest compression per minute, and at least 10 breaths per minute with an advanced airway in situ. So for patients with non-shockable regimes, the early adrenaline is administered after initial CPR is more likely the patients to survive. All right, so adrenaline either intravenous or intraosseous or even through your ETT is very important to ensure likelihood of survival. All right, using a cuffed endotracheal tube decreases the need for endotracheal tube changes. All right, sometimes there are chest compression and you want to minimize aspiration. Sometimes people need to change. Well, earlier use of cuffed endotracheal tube is important. It's been said also that the routine use of crack pressure does not reduce the risk of regurgitation and may actually impede the success of your laryngoscopy and intubation. All right, so for out-of-hospital cardiac arrest, back mask ventilation results in the same resuscitation outcomes as advanced airway intervention. All right, so the fact that the rescuer, or maybe you do not have equipment for laryngoscopy and endotracheal intervention. All right, sometimes you can have easier access to back mask ventilation. Studies have shown that for out of hospital cardiac arrest, the outcomes are similar. So when you are doing CPR, but there's no return of spontaneous circulation, post-cardiac arrest, SLA cardiac arrest care is critically important for this patient. For children who do not regain consciousness after return of spontaneous circulation, you need to target temperature management, all right, to reduce cerebral metabolic requirement or cerebral metabolic rate and oxygen demand. And you want to continue electroencephalography monitoring. All right, the prevention and treatment of reversible causes of cardiac arrest is important, especially as it relates to hypoxia, hypotension, hypercapnia, and hypocapnia. After discharge from the hospital, all cardiac arrest survivors should have physical, cognitive, and emotional challenges, and therefore we need ongoing therapies and interventions. Know that naloxone can help reverse respiratory arrest due to opioid overdose, but it does not seem to have any benefits, especially in patients in cardiac arrest. Fluid resuscitation in patients with sepsis, where cardiac arrest is secondary to sepsis. This is based on patient response and always require frequent reassessment with your IVC monitoring and other forms of fluid resuscitation or fluid management strategies. Balanced crystalloid, whether unbalanced or colloid fluids, any fluid that you can get that is readily available to you, is acceptable for resuscitation in patients with sepsis. Adrenaline infusions are useful, especially if you have dilated IVC and you realize that this patient is being fully fluid resuscitated. Adrenaline infusion comes handy. All right. So quickly, we'll go back to the slides on the sequence following the American Heart Association. All right, so that we can just quickly go through it. I will leave this one because I've gone over it and I've tried to compare 2015 to the 2020 guidelines according to American Heart Association. All right, so you in a scene where a patient has had cardiac arrest, or maybe in theater and all that, or maybe out of hospital. The first thing is that patient is not responsive, patient is not breathing, all right? And that's when you initiate your emergency response system, all right? And if the patient is breathing, normal breathing, and has a pulse, all right, you monitor the patient until emergency responders arrive. But if there's no breathing, but the patient has a pulse, okay, you want to provide rescue breathing, one breath every 3 to 5 seconds or 6 seconds, as the time may be, or about 12 to 20 breaths per minute. This for patients who does not have an airway in situ. Add your compression if pulse remains less than 60 per minute with signs of poor perfusion. It will also augment perfusion to vital organs. Activate the emergency response system if you have not done that, and continuous rescue breathing until help comes, or especially if you are not in a controlled environment like the ICU or theater. Now, there's no breathing and there's no pulse. You want to find out, is it a witness cardiac arrest? A witness cardiac arrest has better outcome, better prognosis. You want to get your AED, because we have established that early defibrillation helps to improve outcome following cardiac arrest. But if the arrest was not witnessed, if you are a single alone rescuer, you want to begin cycles of 10 compressions and give your 2 breaths. And especially for children, you want to do 15 to 2. But if a second rescuer comes along, you want to change your sequence of compression and rescue breath. Don't forget to use your AED when and if it's available. Okay, so this is what I mentioned before. When the AED comes, you want to, it analyzes the reading for you. If it's shockable, you want to give 1 shock, and you receive your CPR immediately for about 2 minutes until prompted by the AED to allow rhythm check. All right, I'm sure many of us are familiar with AED. You continue until you're able to activate your advanced life cardiac, your ALS, all right, comes. So if the rhythm is not shockable from the analysis of your AED, you want to resume CPR immediately and allow AED to do a rhythm check, and you continue until you cascade to advanced life support. All right, these are things we've mentioned before, and these are 2015. So I'll stop here and give room for questions and for discussion. So I